Well, we are getting to the end of the day, and what I'll speak of is very different. I'm not speak of children, I'll speak of parents. So I'll ask you to read this. I'll just say that this is from a book. This book was published in 1976, so that must be many years ago. And it was written in Danish, so I did the translation. So I'll ask you to read this. And after having read it, I'll ask you to sit with the one next to you, I mean the two or three, and then just to discuss and try to discuss between you two questions. The first question is, what kind of human experience is this? And what kind of human experience does this express? And the other thing is, in which conditions is that still something which is relevant for us today, 40 years later? Does it happen? Does it happen in our practice? And the third question, is there anything we could do to influence it? Well, thank you. First, First, I have to explain that the long stockings here, that was a dress code of the time from mothers who were given birth in hospital. They were in hospital clothing, and since it's a winter season, so this is a description of the mothers who delivered in Rigshospitalet in Copenhagen and that year. So she had delivered, so she had been there for some time, so she had this experience, so she wrote this book. So the uniform of mothers who delivered that time, that was sort of hospital clothes, and because this is a cold country, they had long stockings in order to keep warm, and these stockings obviously wouldn't stay up, they would fall down, and this was one way of sort of suffering, that you were sort of walking there. You had to walk from the neonatal department having given off your child because there was a problem, just hyperbilirubinemia and poor sucking, a little bit preterm, nothing serious really. And then you had to go back, but these stockings had to fall down, and she sort of had to pull them up to sort of look at least a little bit decently dressed. So this is part of the distress of being as a mother who is not sick yourself really in a hospital. Another thing which may be just a sort of a historical relevance is that this was our department at the time. It was named GN, which it was actually D. That was because when the hospital was built in the mid-19th century, it was just one department, and it was actually only medicine, because by that time surgery hadn't really come because there was no anesthesia. And then the hospital grew, so it was too much for one consultant, so they needed two doctors, so they got each one a department A and B. And then surgery came about, so D and C and D, and then I, and then when it got to children, they had got to the letters G, and then when we got to neonatology some 50 years later, that was the GN. And because at that time we didn't have a civil registration system, it was considered very important that every baby was very clearly identified. And since in Denmark sometimes you have the name of your mother and sometimes of your father, and your given name has not been given yet, so they just decided that it was better to give every child a number. So it would be GN number 29, because that was the 29th admission that year. And that GN 29 was perfect for our purpose, because that would make it absolutely certain that we would be intubating the right infant or looking at the right X-ray. But unfortunately, here seen from this artist and mother's perspective, this is obviously strange. And in order, here at the time, they were very friendly. They were sort of oriented towards customer service. They were telling her when she could come and see her child, when other family members could come and see her child. And she was even given an information sheet with this GN 29 to make sure that she remembered, so she would ask, she would sort of, it was an efficient and correct information in case she would call, telephone, call and ask, or the husband would call and ask about the progress. But the dramatic aspect obviously was this, that she couldn't rid herself of the thought that she carried a small certificate of death in her pocket. This is very, I think, is a very dramatic artist, author's expression of this, what I think would say, this is it's a feeling of separation, it's a loss. She has taken care of this baby for 3 days. It has certainly not been easy, a bit preterm, jaundice coming up, problem of sucking, and then she hand over, she's told it's better that you hand over. And she realizes, because she's a well-educated, civilized Danish subject mother, she realizes that it is better she hands over. But that doesn't rid her of a feeling that this is a separation, and this is really a death, a small death. And the question obviously is, how often do we elicit this reaction in our practice? So this is, this book actually came to form a bit of a care culture. There were other inputs also. So from the mid-70s in the department at Rigshospitalet, we became very sort of exposed to the sentiments of parents. And we also got into that thinking that actually, rather than looking at a child and parents, you're looking at a family unit. And the future of a child very much depends on how these family units end up functioning. And by that time, there was obviously a lot of concern about separation and loss of relation, difficulties of establishing relation. There was also a small literature, mainly from the United States, showing that ex-preterm infants were mistreated, abandoned because of lack of this normal development of a caring family relation. So we were sort of very much addressed, and there were 2 psychologists doing projects in this in the late 70s, so we became very sort of adopted to sort of think that the parents were part of, they were also patients, they were somehow also our customers, they were also suffering, and that if they were, their problems were minimized, then they would do better in helping their children, so the work we were doing in making these children survive will actually end up, so it will end up being better for the child also. But the primary effect was really not the primary effect on the child, but that was the primary effect on the parents. And therefore, this was one of my motives to enter these European collaborations about family-oriented practice. We had a network which was headed by Jacques Sisson from Brest in France, and we were these countries. And this is just showing the enormous differences across Europe when it comes to practices concerning how parents are accommodated in neonatal units. So one column here is that it is allowed for both parents to stay 24 hours a day. Could they come and go, as you saw in the 70s, parents were allowed for 30 minutes a day. Then allowed for both parents over 24 hours to visit whatever regards to their issues about what about ward rounds, what about nursing rounds, and there's also whether they could stay during procedures. I mean, there's clearly an issue here. If you have to intubate a child, would that in order to sort of make it easier for the staff to intubate, or whether it makes it easier for the parents to, I mean, is it not too much for the parents to be present? That's also an issue. Anyway, big differences in practice across Europe. And this is just a picture I got from that father. He made a series of pictures, and this just illustrates the collaboration between the nurse and the father. So parents are really very much involved. So they sort of end up doing many, many procedures. They don't twist ventilators, but they do sometimes increase and decrease oxygen. They can read off oximeters, so they can do. So they sort of enter under the provision that this is their child. And this is well. This was a part of the output from this European Science Foundation Research Network. This was very much inspired, I would say, by Dr. Levin's. He was from Lithuania, no, Estonia, I'm sorry, Estonia, and he had this human neonatal care initiative, which was a kind of a paraphrase, or what would you call it, of the WH baby-friendly hospital, but the baby-friendly hospital is for term infants, so he wanted to create something similar for preterm infants, where it was, where it's sort of, at least stated, and that becomes a policy that you try to address these issues. So this is my last slide. It is just showing something we learned from Sweden. So here we have an incubator, and here we have a trolley with a ventilator and monitor and different kinds of things. And here you see the link, so it can be detached. So what we have done now for a number of years, that we started actually, it started actually because we came out of a tradition of being relatively conservative with the resuscitating, life-sustaining treatment of the smallest and the immature. And we had a process, a social process in my country, involving quite a lot of parties discussing the reason behind making a fixed lower gestational limit for resuscitation. But in the end, the conclusion was that, as I think we discussed during the workshop, that there are many other issues entering this equation. It's not only gestational age, it's also sort of birth weight, and it is pregnancy complications. It's a particular condition of the child at birth. There are also parents' attitudes and parents' conditions. So many things enter into this. So we had quite some years of practice where we would sort of come over to an extremely preterm delivery. We would, as far as possible, have cleared this with the parents, but quite often also said that the condition at birth would also mean something. And what we then would do would be to sort of try to stabilize the baby with minimal means, nasal CPAP perhaps, and then put that baby in the incubator, keep it warm, make sure that we were not losing anything serious, staying in the room, staying with the parents. The father wouldn't have to sort of decide whether he would stay with the mother or going with the baby. Staying in there, allowing time, minutes, even hours to pass without having to sort of make a definite decision. So very different from what we used, where we would sort of at a certain point in time say either, okay, we have the baby here, baby perhaps go to the maternal, to the chest of the mother to die, or we will have to take the baby onto the unit in order to make sure that we are optimizing treatment. So this was actually meant for supporting this process of getting a decision about life support extended over a period of time where the baby's condition at birth could be part of the parents' base of decision. And also, sometimes you see that parents, change opinion once a baby. One thing is to relate to an ultrasound picture of something and to some numbers. Another thing is to relate to a baby who's practically born. But now it is actually the way we try to do it also with babies who are certainly going to take care of, because we say if you're not going to do anything more than we could actually do in the incubator with whatever we need in the labor room or in the cesarean section room, then we don't need to force this separation.